I'm Antoni Chan, reporting here at ACR 2024 for Room Now. And one of the key highlights of today was the new preliminary ACR guidelines on the use of ultrasound in both rheumatoid arthritis and also psoriatic arthritis. I wanted to focus on the psoriatic arthritis area because it's one of the areas that I find clinically quite challenging to assess patients, especially when they don't always present with very straightforward clinical signs. And ultrasound will be a benefit. And I'm very happy that I can be joined by the lead author from this morning's presentation, Dr. Bakewell from Salt Lake City.
Yes.
And she presented the work today. So welcome.
Thank you so much for having me. It's a pleasure to be here.
So tell us about the work that you've been doing with regards to developing these preliminary guidelines.
Absolutely. So this has been a labor of love, as you heard this morning. It's been about a 2-year project. On the psoriatic arthritis side, I can tell you we had convened first with 13 different experts in addition to the core panel that developed a series of what we call quick-go questions. And the idea was to ask how can we better use musculoskeletal ultrasound and psoriatic arthritis both for diagnosis, contextualizing findings, determination of treatment escalation and remission. And we then went through the literature. There's the real labor of love. It was over 3,800 articles that we came up with for ultrasound and psoriatic arthritis. And a series of 19 different literature reviewers whittled it down to just over 150 documents. And then we had a voting panel of 10 folks who were able to bring forward with a 70% consensus 20 different BIPA statements or guidance statements that you heard this morning. And thank you for coming and listening to that.
It was a very stringent methodology.
Yes.
Lots of review and lots of people getting involved in it. So just tell us what is the main difference compared to the 2012 guidelines? So it's 10 years down the line. What's different this time?
So for better or for worse, truly for better, but it made this a challenging project. There has absolutely been an explosion in the number of papers published in the field of musculoskeletal ultrasound since the 2012 guidelines were published. A big difference just in the structure of what the output will be is that in 2012 it was looking at the application of musculoskeletal ultrasound across the field of rheumatology, stating various areas where it was reasonable to use musculoskeletal ultrasound to evaluate for inflammatory disease and making statements like, for example, that SI joints would not be an appropriate location in the absence of the availability of other imaging modalities. But this is truly focusing on rheumatoid arthritis, psoriatic arthritis, and narrowing it down to clinical application and day-to-day practice for the everyday rheumatologist. It's not meant to be just in clinical trials.
So these guidelines are, in many ways set the standards for us or what we should be looking for. But also I was very attracted to, how do we use this practically in clinic. So if you could share with us some of your thoughts about how we're going to translate this into clinical use.
Absolutely. So first and foremost, when we talk about diagnosis, we talked this morning about the concept of ultrasound and enhanced CASPAR classification criteria. So can we use musculoskeletal ultrasound to determine who we would even put through the CASPAR classification criteria? Who can we confirm inflammatory articular disease? So joints and theses or spine are kind of the 3 categories that CASPAR refers to. So there's looking at diagnosis. We talked a lot about not only escalation of therapy, but determination of flare and what constitutes a flare. And we talked about the concept that clinically normal joints can have ongoing synovitis, and clinically swollen joints can have cool residual fibrotic synovium. So you put the ultrasound transducer on and there may be no Doppler signal because somebody actually has burnt out or quiescent disease. But again, you feel that it's so swollen. And so one of the statements was MSUS can confirm the presence of flare. And that is also helpful in that patient-provider discordant situation, right? So a patient comes in and they may have significant synovitis on exam, but they're saying, look, doctor, I really only want to use my doTERRA oils. I really don't want these. I've read the package insert. This medicine concerns me. And it's so helpful to be able to put on the transducer, show them the Doppler signal, lights up like fire, or you may have a large erosion and they say, oh, this is really causing damage. This has a different risk-benefit ratio than I was thinking. Or the opposite is also true. So the patient with psoriatic arthritis and fibromyalgia who comes to you and says, doctor, my psoriatic arthritis is flaring, and you look at them and they look pretty good, they may not feel like they were taken as seriously if you don't have an extra look at the ultrasound, show them the absence of Doppler signal, so that they really feel like you look underneath the skin and you're telling them, look, this is not your psoriatic arthritis that is flaring. Let's talk about other ways we can help your pain.
And that to me is one of the key highlights from your presentation this morning, of how you can take a guideline and then put it into clinical practice. My short of it is turning the what for us is a very subjective assessment to an objective assessment.
Yes.
You know, so the subjective becomes objective because of MSUS. And I think the big area that we maybe struggle is enthesis, enthesitis, because they're quite hard to sometimes assess.
Yes.
So maybe a few words about maybe how we can take that kind of forward with this new guidelines with the use of MSUS, because you did show some very nice work there.
Thank you. Enthesitis is such a key element or domain to assess, and thank you, Tony, for bringing that up, because all of the agents that we are shown now that say, hey, look, this works for enthesitis, we're talking about clinical enthesial indices where the provider presses, the patient says, ouch, that's counted as enthesitis. If they don't say ouch, it's counted as no enthesitis. So again, your patient with fibromyalgia all of a sudden has enthesitis, and your patient with subclinical inflammation who doesn't say ouch but is still inflamed doesn't even get counted towards the tally. So there really is a need for that objective assessment that ultrasound provides us. So we talked about the elementary lesions of enthesitis and how this can be used, especially for diagnosis, but also monitoring of treatment and remission.
I think that's really excellent. It kind of takes us to a different level. So just to wrap up, what would you say for our audience, the key take home from your session today?
If you have not started scanning yet, now is the time to get into it. And I think we all are so busy in our day-to-day practices, I completely understand both the costs and the time limitation. But I do believe that this is a powerful tool. It just gives us more information to work with and base our clinical decisions off of. And I really do consider it my stethoscope in day-to-day practice. So I get out there, buy one, it's worth it.
All right, there, start scanning, start going, start looking at it. So you can refer to the video or the slide from today's presentation. And it gives you the outline of the preliminary guidelines, and I think this is something that will certainly help us in our clinical practice. So Catherine, thanks very much for your time, and this is Antoni Chan reporting here from Washington at ACR 2024.